lesion set. Here we go.
Good morning, everyone. My topic is ablation in selective patients with long-standing persistent atrial fibrillation, medium-term result of the Dallas lesion set. This study was from the Beijing Annual Hospital, and now I am a visiting scholar in the University of Michigan, and I think it's really a great experience for me to study there. Okay. As we know, the minimal invasive ablation has been proved to be effective in the treatment of the paroxysmal AF. However, in the patient with long-standing persistent AF, it has had limited success and is associated with a high incidence of recurrence. Dr. Atrial described the Dallas lesion set that closely replicated the left atrial lesions of the Cox-Maze 3 procedure in 2006. And their early result suggested this minimal invasive approach with extended lesions increased the efficacy over the pulmonary vein alone in the treatment of the patient with long-standing persistent AF. In our present study, we employed the Dallas lesions set in an attempt to improve the surgical results in patients with long-standing persistent AF, and we also evaluate the change in the left atrial volume and function by the three-dimensional echocardiography. Between 2009 and 2011, there were 103 patients with long-standing persistent AF underwent video-assisted thoracoscopy surgical ablation in our hospital. Patients with a prior catheter ablation, severe structural heart disease, and left atrial diameter more than 65 millimeter or ejection fraction less than 14% were excluded from our study. Here is the baseline characteristics of our patients. We can find the mean AF duration was about 5 years. The mean left atrial dimension was about 55 millimeter, and there were nearly 60% of patients, the CHIS2 score were more than 2. The surgical procedure we did as a protocol described by Dr. Wolf and Dr. Atrial. It includes the pulmonary vein isolation, the roof lesion line, the trigonal lesion line, division of the ligament of the muscle, and ablation of the ganglionic plexus, and amputation of the left atrium appendage. Before the procedure and during the follow-up, we did the three-dimensional echo for each patient. During the follow-up, patients were seen at our outpatient clinic at 6 months, 1 year, 2 years, and every 1 year thereafter. A routine three-dimensional echo, ECG, and 14-8-hour order were taken at each visit for every patient. Freedom from recurrence was defined as the absence of arrhythmias without using any anti-arrhythmia drugs after the procedure. In our study, during the follow-up, we divided the population into the two groups depending on whether they have a recurrence. There were no in-hospital mortality and other severe procedure-related complications in our study. Only one patient had a prolonged chest tube placement for pleural effusions. During the follow-up, only one patient required pacemaker implantation for sinus node dysfunction. There's no stroke, no TIA were observed during follow-up. This is a rhythm change. We can find at the 6 months follow-up, there were 84.5% patients were in sinus rhythm, in which 79.6% patients were off anti-arrhythmia drugs. And at the 2 years follow-up, there were 18.6% patients were in sinus rhythm, in which 74.8% patients were off anti-arrhythmia drugs. And at our latest follow-up, there were only 71.8% patients were in sinus rhythm, and there are still 20% patients in atrial fibrillation, 16.8% patient with atrial flutter. And this is a Kaplan-Meier analysis, we can see there's a decline during the follow-up of the freedom from recurrence. This is a left atrium volume and function change during the follow-up. We can find during the follow-up, there was a significant reduction of the left atrial volume with the significant improvement of the left atrial function in the sinus rhythm group. However, in the AF group, there was no significant change either in the left atrial volume or the left atrial function. Here is an example patient in the sinus rhythm group with a significant reduction of the left atrial volume, maximal volume, and minimal volume at the 6 months after the procedure. We find the predictors of the recurrence by the Cox regression analysis. In the univariate analysis, the duration of the AF, the left atrium diameter, and the chest-2 score more than 2 were all the predictors of the recurrence. But in the multivariate analysis, only left atrial diameter was remained as predictors of the recurrence. In order to determine the role of the left atrial diameter in our study, we did another studies. We find that in the sinus rhythm group during the follow-up, the left atrial diameter decreased significantly by almost 6 millimeters. However, in the AF group, the left atrial diameter did not change significantly during the follow-up. This is a received operating characteristic curve analysis. It showed that an left atrium more than 55 millimeter was the optimal cutoff value to discriminate the patient from the recurrence discriminate the patient with recurrence from those without recurrence. Also, in the Kaplan-Meier analysis, we also find left atrial dimension more than 55 millimeter was a significant predictor of the recurrence. Okay, based on the above result, this study demonstrated that a good success rate and a low complication rate are achievable in patients with long-standing persistent AF using the Dallas lesson set. The Dallas lesson set resulted in our experience in a significant improvement in left atrial volume and function after the restoration of the sinus rhythm as demonstrated by the 3-dimensional echo analysis. Also, there are some limitations of our studies. For example, it was relatively small sample size, it was absence of a control group, and it was a single center study. So I think our result of the present study need to be confirmed in a larger population with a longer clinical and echo follow-up. That's all for my presentation. Thank you so much.
Okay, thank you very much. The floor is open for the questions. Dr. Wolf?
I think maybe you have the best English of anybody I've heard from Anjan Hospital.
Thank you so much, Dr. Wolf.
Very nicely done. We've been talking about whether or not left atrial appendage is important and whether it should be remain or removed in atrial fibrillation surgery. But here you show very clearly probably that if the heart is in sinus rhythm, that's so much more important than whether or not you remove the appendage. That's what it apparently shows, because you have significant changes in the left atrial volume, even though in all these patients you did remove the appendage, correct? You did remove the appendage in these patients.
Yeah, we removed the appendage in all the patients.
And despite that, what you showed was significant improvement in left atrial volume. So maybe the improvement is so great of being in sinus rhythm that it doesn't matter that you removed the appendage. What do you think about that?
Thank you. And actually, during our during our ongoing study, we did a comparison study with surgical ablation and catheter ablation, because the catheter ablation will do not ambulate the left appendage. So from that study, I think we can find whether the reduction of the left atrial volume is depend on our surgical research, because we cut off the left appendage. So maybe that study result will be helpful for us to understand the appendage in the during the treatment of the AF.
Dr. Damiano?
Excellent study and very nice reporting of your results. I'm wondering now with the results, with your knowledge that the procedure doesn't work well in left atrium over 55 millimeters or 5.5 centimeters, do you offer those patients a different operation now in the large left atrium?
Now in our hospital, actually the patient itself, whatever the left atrium, the diameter, for example, if the patient has a very large left atrial diameter, but the patient wants to do the procedure by himself, our doctors, the guideline of our hospital, there's if the patient's diameter was more than 65 millimeter, we did not do the procedure.
Do you offer them a minimally invasive maze procedure?
Yeah, I mean the minimal invasive procedure. We did not do the procedure for the patient with a left atrial diameter more than 65 millimeter. But if the diameter is between the 55 millimeter and the 65 millimeter, we also did the minimal invasive procedure for such patients.
Okay. You don't offer them any other procedures then?
No.
In the big atrium. So it's either that or nothing.
You mean the big atrium?
Yeah, you never do a maze procedure.
Yeah, we never did the big atrium for the minimal invasive. Also, the bypass, although the maze procedure, if the patient was only the atrial fibrillation without the constructive heart disease, we did not do the minimal invasive procedure.
Okay.
Thank you.
Thank you. So we move forward to the next presentation
Thank you so much.
by